Subcommittee on Border Security, Facilitation, and Operations will come to order. The subcommittee is meeting today to receive testimony on assessing the adequacy of DHS efforts to prevent child deaths in custody. Without objection, the chair is authorized to declare the subcommittee in recess at any point. The chair asks unanimous consent that Representative Underwood be permitted to sit and question the witnesses. The chair asks unanimous consent that Representative Garcia be permitted to sit and question the witnesses. Without objection, so ordered. Jacqueline Call McKean, 7 years old. Felipe Gomez Alonso, 8 years old. Darlene Cristabel Cordova Valle, 10 years old. Juan de Leon Gutierrez, 16 years old. Wilmer Josue Ramirez Vasquez, 2 years old. Carlos Hernandez Vasquez, 16 years old. These 6 children died in the custody of the United States government just in the past 18 months. These children were migrants from Central America who died of preventable conditions that went untreated. And 3 of these children spent the last hours of their lives in detention facilities on our southern border. We must never forget their names, their suffering, or the terrible losses their families had to endure. So we are here this morning to examine the conditions that led to these avoidable tragedies. We've seen a dramatic increase in the numbers of families and children arriving on the southern border over the past several years. Most of these families and children arrive from Central America, fleeing vicious cartels, gang violence, and extreme poverty. And after surviving long, dangerous journeys, these families should have been met with safe refuge. But instead, they encountered this administration's myriad of inhumane border policies, like family separation, zero-tolerance detention, and the Remain in Mexico policy. These policies and management decisions by the administration have contributed to mass overcrowding and widespread inhumane conditions at Customs and Border Protection facilities across our southern border. Numerous reports by the DHS Office of Inspector General and court observer attorneys confirm these intolerable conditions. I've seen the problems with these facilities with my own eyes, along with several of my congressional colleagues on this panel today on both sides of the aisle. Yet when pressed about these conditions, DHS has consistently failed to maintain transparency by stymieing congressional inquiries. This raises concerns that they are hiding serious issues with management, in addition to the leadership vacancies at the top of the department. One example of this is the department's decision to conceal information on the death of Carlos Hernandez Vasquez. Carlos was a teenage boy from Guatemala who died tragically in U.S. custody on the morning of May 20th, 2019. CBP issued a press release later that day calling the death a tragedy and declaring that they considered the health, safety, and humane treatment of migrants to be of the highest priority. However, despite information requests by this committee, it was not until a ProPublica report was released 7 months later that Congress and the public learned more about what happened to Carlos, that his death may have been caused by the failure to provide urgently needed medical care and the failure to follow the most basic procedures to simply check on a sick child. While I understand that this specific case is still under investigation, this lack of transparency by the department is completely unacceptable. The Office of the Inspector General must be doing everything in its power to examine the factors that led to these tragedies. And that's why I'm extremely disappointed that the current DHS Inspector General declined our invitation to testify this morning, especially given the recent news that his office closed its investigations into the first 2 child deaths in Border Patrol custody. The publicly available summaries of these investigations are extraordinarily narrow in scope. They focus only on whether DHS personnel committed malfeasance and not whether the department's policies and resources could properly protect the children in its care. For instance, even with these 2 completed reports, we still do not know why Felipe Gomez Alonso and his father were in CBP custody for 6 days before Felipe passed away. I, along with several other members of this committee, remain concerned that DHS still isn't doing enough to protect the children in its custody. Reporting over this past weekend indicates that CBP continues to detain families with young children in need of medical attention well beyond the 72 hours allowed by the agency's own protocols. This is a disturbing pattern that needs to be remedied immediately, or we risk losing more children to preventable deaths in the future. We must act urgently to ensure that the policies and decisions that contributed to these tragic deaths are addressed. I hope the witnesses here today are prepared to explain whether the department's current approach incorporates the lessons learned after these tragedies and how they intend to safeguard children in DHS custody going forward. As members of Congress, we may disagree about immigration policy, but there should be no disagreement that the federal government must take responsibility for the human beings in its custody, particularly young children. We must never forget Jacqueline, Felipe, Darlene, Juan, Wilmer, and Carlos, and we must never let this happen to another child again. I want to thank the witnesses for joining us, and I now recognize the ranking member for his opening statement.
Thank you, Madam Chair, and I thank our professionals for appearing before us today, the panelists. I thank Chiefs Hastings and Dr. Eastman for your service at the border and for being here today. I look forward to hearing in greater detail about the actions DHS has taken to enhance Customs and Border Protection's ability to handle migrants arriving at our border and deteriorating health and to address preventable deaths in custody. The crisis that unfolded along our border last year was real. It was not the fault of the men and women of Customs and Border Protection. It wasn't the fault of the executive branch nor the President of the United States. The truth is, this past year, we saw record numbers of family units, unaccompanied minors, large groups of 100 migrants or more, 213 groups to be exact, arriving at our border during the height of flu season and during months of extreme heat. At the time, the Border Patrol was referring 50 cases per day to medical professionals. The border crisis was a result of legal loopholes, activist judges, propaganda from criminal cartels, killers who smuggle and traffic migrants for profit. In 2014, under the Obama administration, the number of unaccompanied minors encountered at the border was viewed as crisis level, leading to former DHS Secretary Johnson writing an open letter to Central American parents telling them to not send their children. It's clear that sufficient corrective actions were not taken at that time. If that was a crisis, then there are no words to describe what we experienced at the border during fiscal year 2019. Not only were more than 321,000 minors encountered by Customs and Border Protection, family unit apprehensions were more than 590% in fiscal year 19 as compared to fiscal year 14. Throughout the crisis, most CBP facilities were at or over capacity. Customs and Border Protection personnel were working overtime for more than a month without pay to process the large groups. Resources were depleting at record time as key personnel at the department were furloughed. Yet Customs and Border Protection law enforcement officers still scraped together enough money out of their own pockets to buy toys and bring extra supplies for the migrants in their custody. Many of them parents themselves, caring for and loving to the best of their ability the children in their custody. After a 35-day shutdown that began in the end of 2018, the federal government reopened in January 2019, and the crisis continued. In light of the growing issues related to the mass influx of migrants, President Trump made an official request to Congress for supplemental funding for the border. 2 months went by before we sent that money to the field. My colleagues across the aisle blocked the vote on supplemental assistance more than 15 times. While leaders of the majority party were repeating the message of tweets like fake emergency, the chief of the Border Patrol was testifying in front of Congress that without the funding, we may, quote unquote, lose the border. The Bipartisan Homeland Security Advisory Council released a report on the crisis stating that the delay in passing a supplemental resulted in unaccompanied minors being held in Customs and Border Protection facilities for dangerous lengths of time. There are members on this committee who voted against the emergency supplemental. A no vote meant a vote to keep unaccompanied minors in Customs and Border Protection custody instead of at a Department of Health and Human Services facility suitable for children. It meant releasing thousands of migrants on the streets of border communities. Boulder County Sheriff Napier testified before this committee that during the crisis, social service resources that should address local issues of hunger and homelessness are now completely unable to do so. While the men and women of CBP were struggling to keep the lights on at the border, they were the subject of partisan attacks. One member even claimed that the deaths of children in custody were intentional. An ugly statement, an absurdity that was completely debunked, as the DHS Inspector General found no misconduct or malfeasance by DHS personnel upon completion of their investigations into the heartbreaking deaths of Jacqueline and Felipe in December 2018. Every life is precious, and even one death in custody is too many, which is why I am encouraged to learn about the immediate steps CBP took to enhance their ability to diagnose the health of migrants in custody and work with the DHS Chief Medical Officer to make long-needed, long-term improvements. In December 2018, then Commissioner Kevin McAleenan ordered secondary medical checks on every child in custody and initiated an internal evaluation of CBP care policies. Since then, CBP established a phased approach to conducting health interviews on all migrants during initial processing and a subsequent full medical assessment of all unaccompanied minors and at-risk adults. On top of that, Customs and Border Protection now has over 700 medical personnel and contractors stationed across the southwest border to provide medical support to migrants in custody. Today, I look forward to hearing from our witness about how CBP's in-custody medical capabilities have improved since the fall of 2018, the collaboration process between CBP, the Office of DHS Chief Medical Officer, and other relevant stakeholders to bolster Customs and Border Protection's ability to stop preventable deaths in custody, and their expert opinions on how to prevent another crisis in the future. Madam Chair, thank you for your indulgence, and I yield back.
Thank you, Mr. Higgins. The chair now recognizes the chairman of the overall Homeland Security Committee, the gentleman from Mississippi, Mr. Thompson, for an opening statement.
Thank you very much, Madam Chair. Good morning to those of you who are here on the committee. Today's hearing topic is sobering, as it centers on the death of innocent children. In our current hectic and rapidly changing political environment, it can be easy to move on quickly from past disasters and tragedies. The Trump administration contributes to this situation by piling scandal on scandal, exhausting the public, the media, and oversight organizations. It is our oversight responsibility as members of Congress to refuse to allow the most disturbing and upsetting events fade into the past and help ensure that they are not repeated. We're here today to examine the treatment of migrant children in the custody of the Department of Homeland Security in 2018 and 2019, and look at what changes may still be necessary. Certainly, detention of migrants did not begin with the current administration, but in earlier administrations, both Democratic and Republican, officials took steps to avoid risking the health and safety of the most vulnerable people in custody. Under the Trump administration, we now find the elderly, the infirm, and children in detention facilities, such as Border Patrol stations, not designed or equipped to hold people for extended periods of time. When arrivals at our southern border began to rise sharply in 2018, the decision to detain everyone led to severe overcrowding. The DHS Office of Inspector General, attorneys, and members of Congress, including me, observed and reported on the conditions inside these facilities for months. CBP argued throughout this crisis that they faced severe resource constraints despite Congress providing billions in humanitarian funding in early 2019. Standing room only sales, inadequate hygiene products, and family kept outside in extremely variable temperatures were commonplace at CBP facilities during the height of migrant arrivals last year. In such an environment, the spread of illnesses, such as the flu, are inevitable. Whether individual deaths can be directly attributed to specific conditions in a given facility or not, we need to understand whether the policies and resource management decisions made by the administration put lives in jeopardy. Congress cannot allow DHS and CBP leaders to make poor decisions or ignore existing policies and law for purely messaging reasons. Secure borders are a priority for our country and for all of us on this panel, and have been for decades. Part of our responsibility as members of Congress is to check actions by the executive branch that are misguided. Hearings such as this are a critical part of that effort. I have strong objections to the policies the Trump administration has put in place along our border that continue to endanger the safety of migrant children, such as remain in Mexico. I hope to hear from our DHS witnesses this morning that the department will take its responsibility toward people in its custody more seriously going forward. One child death was one too many. I'm eager to know what the department plans to do differently in order to safeguard children's safety while in DHS's custody. I thank the chairwoman and ranking member for holding today's important hearing, and I yield back.
Thank you, Mr. Chairman. Other members of the subcommittee are reminded that under the committee rules, opening statements may be submitted for the record. I welcome the panel of witnesses. Our first witness, Mr. Brian S. Hastings, is Chief Law Enforcement Operations, U.S. Border Patrol, U.S. Customs and Border Protection, Department of Homeland Security. Brian S. Hastings is the Chief of the Law Enforcement Operations Directorate at U.S. Border Patrol Headquarters in Washington, D.C. He is responsible for oversight of the day-to-day law enforcement operations at Border Patrol sectors throughout the United States and is a principal advisor to the Chief of the Border Patrol on enforcement operations. Chief Hastings began his service with the Border Patrol in 1995 and has been stationed in various sectors across all U.S. borders and was promoted to the Senior Executive Service in 2018. Our second witness, Dr. Alexandra L. Eastman, is the Senior Medical Officer for Operations within the United States Department of Homeland Security's Countering Weapons of Mass Destruction Office. In this role, he is responsible for operational medicine across DHS, in addition to countering threats to the U.S. worldwide. Previously, Dr. Eastman served as the chief of the Reese Jones Trauma Center at Parkland Memorial Hospital and as an assistant professor and trauma surgeon in the Division of Burns, Trauma, and Critical Care at the University of Texas Southwestern Medical Center. Dr. Eastman is also a decorated police officer within the Dallas Police Department. Without objection, the witness's full statements will be inserted in the record. I now ask each witness to summarize his statement for 5 minutes, beginning with Mr. Hastings.
Good morning, Chairman Rice, Ranking Member Higgins, and members of the subcommittee. As part of CBP's mission to safeguard America's borders, we completed initial processing of individuals in our custody before transferring them to our partners. While our holding facilities were designed for only short-term custody, we take seriously our responsibility to protect and care for individuals until they can be transferred. During fiscal year 2019, CBP apprehended or found inadmissible more than 1.1 million people. In December of 2018, we began alerting Congress, the media, and the public that an unprecedented spike in Central American families and children was creating a crisis on our southern border. For months, our request for immediate legal and emergency funding went unanswered, and we began diverting resources from our border security mission to address the crisis. As I prepared to testify before you today, I reflected on the numerous actions CBP has taken and continues to take in response to this crisis. I could not be more proud of the extraordinary efforts undertaken by the men and women of CBP. I would like to share with you many examples today of the challenges we faced and our rapid actions to address them. First, as the apprehension skyrocketed, we had more people in our custody than we could quickly process. We continued to prioritize processing of UACs first, followed by families, and then single adults. CBP surged more than 1,050 officers and agents to the busiest sectors. As many as 40 to 60% of our agents were diverted from securing the border to caring for those in our custody. Over 700 DHS personnel provided support at our facilities. We expanded our transportation contract and purchased more than 200 buses and vans to expedite transportation of large groups of migrants. We chartered planes and drove busloads of more than 43,000 people from overwhelmed locations to facilities with more processing capacity. Second, even when processing was complete, ICE and HHS had limited capacity to accept aliens, which contributed to further overcrowding in Border Patrol facilities. In March of 2019, Border Patrol began releasing non-criminal family units directly into the United States rather than transferring them to ICE. During fiscal year 19, a total of 145,000 family members were released. CBP rapidly constructed 6 soft-sided facilities that provided capacity for an additional 6,500 families and adults. By June, Secretary Azar stated HHS shelters were full and they could not accept UACs from Border Patrol custody. When HHS received supplemental funding in July, the number of UACs in our custody quickly dropped from a peak of 2,700 down to 300. Third, we addressed the need for amenities that our short-term holding facilities were not designed to provide. We outfitted the new soft-sided facilities and our highest volume stations with portable showers, toilets, sinks, laundry, climate control system, and kitchen equipment. We expanded our food service contract to provide millions of meals and stock countless snacks, water bottles, clothing, and hygiene items. Finally, we accelerated the expansion of our medical support program. CBP issued interim medical directive in January 2019, which was superseded by an enhanced medical directive in December. This directive sets forth foundational levels of medical support for CBP. It utilizes a phased approach through initial observations, medical interviews with a standardized health questionnaire, and medical assessments to identify potential medical issues and low acuity treatment. In the last year, CBP has dramatically increased the number of contract medical professionals to more than 700. While we built this capacity, U.S. Coast Guard and Public Health Services medical personnel were dispatched to many of our facilities. Now, on any given day, approximately 300 contract medical personnel are engaged at more than 40 facilities along our southwest border, providing 24/7 on-site medical support. Our medical support follows a family practitioner model, which has been observed and validated by medical experts. This model ensures our medical providers are trained, licensed, and credentialed to care for all populations in our custody, including children and pregnant women. Physicians, to include pediatricians, provide oversight and training, consultation for medical direction, and medical quality management. On-site medical personnel may provide care, write prescriptions, or recommend advanced care in the local healthcare system. In the last year, nearly 250,000 juveniles and more than 296,000 adults have received medical interviews. Nearly 60,000 juveniles and more than 95,000 adults have received medical assessments. During fiscal year 2019, Border Patrol took a total of 26,000 people to a hospital or a medical facility when advanced care was needed or requested. Agents spent more than 319,000 hours providing transportation to and from medical facilities and on hospital watch. Today, with the help of our interagency partners and our governmental partners in the hemisphere, we have effectively ended catch and release at the border. The flow of aliens has dropped by 72%. However, these initiatives, like the supplemental funding, are only temporary fixes. As we've said many times before, Congress must close the loopholes in our immigration service system that serve as pull factors. or we risk returning to or exceeding peak levels and overwhelming our immigration system yet again. Thank you, and I look forward to your questions.
Thank you for your testimony, and I recognize Dr. Eastman to summarize his statement for 5 minutes.
Good morning, Chairwoman Rice, Ranking Member Higgins, Chairman Thompson, distinguished members of the subcommittee and guests. It's an honor to be here today to discuss the Department of Homeland Security's efforts to prevent child deaths in custody through our provision and expansion of medical care during the recent migration crisis. I'm Dr. Alex Eastman, the Senior Medical Officer for Operations at DHS. I've been a practicing physician for nearly 20 years, and in addition to my role here at DHS, continue to be a practicing trauma surgeon and surgical intensivist. Immediately prior to coming to DHS, I was the chief at the Reese Jones Trauma Center at Parkland Memorial Hospital in Dallas, Texas. At Parkland, we cared for human beings from all backgrounds in their most desperate time. You care for everyone without regards to race, color, creed, means, religion. Quickly, it becomes apparent that when life and death are on the line, none of these things matter. Providing care for patients, no matter the challenges, was my goal then and is our goal now. From all your visits to the border, and it's nice to see you all again this morning, I know you're aware that we continue to improve the care for all people in our custody, especially children. From the medical perspective, the crux of this humanitarian crisis was a massive increase in the potential demand for care, at times nearly 400%, a number that would gridlock any conventional healthcare system. Additionally, while correctional facilities have embedded detainee healthcare systems, law enforcement agencies do not. CBP is primarily a law enforcement organization, never designed to have a healthcare system within its walls. Doing so would be akin to building a minute clinic in every police station in America. Yet our challenge, in the midst of this crushing demand, was an unconventional problem that required an unconventional solution to help CBP and our other DHS components rise to the tasks of providing care to an overwhelming number of people, including children in our custody. The expansion to where we are today, the system currently in place, and the direction we are headed represents a Herculean effort in response to an unprecedented challenge. In December 2018, the DHS Secretary directed the provision of immediate assistance with the rising humanitarian demands of the migration crisis. We immediately deployed, and for the last 13 months, have been working on the border alongside colleagues from CBP, ICE, federal agencies like HHS and CDC, as well as state and local public health, medical experts, and professionals to improve the care of migrants in custody, with particular attention to the children and the most vulnerable adults the law directs us to hold. Our first priority was to rapidly and urgently expand our medical capabilities along the southwest border, particularly at CBP, which had the biggest need. In support of this mission, the United States Coast Guard deployed more than 30 teams to the southwest border, providing more than 3,450 medical officer days and more than 8,275 health service technician days of care in the rapid response to this crisis. The Coast Guard served as our lifeline, our immediate response force from a medical standpoint. America should be grateful for the truly life-saving and timely work of the Coast Guard during this crisis, as well as so many others. DHS also received critical assistance from the United States Public Health Service. Our nation's Assistant Secretary for Health, Admiral Brett Jawah, himself a pediatrician and intensivist, was a critical partner as we facilitated the targeted deployment of public health service officers to critical areas along the southwest border. There were more than 475 public health service officers deployed to the border, totaling more than 6,750 days of care provided to migrants. No mission was too difficult, including even loading into helicopters and going to our most remote border regions to immediately begin assessing migrants and providing any care necessary as early as possible. When large groups overwhelmed us in areas without public health service or Coast Guard assistance, we moved them there. These two organizations gave so freely of their time and expertise. The officers and physicians and nurses who came down saved lives directly and continue to do so with the legacy they have left along the southwest border. As the interagency was countering the crushing surge, CBP was diligently working to build the system that would assume care from the emergency responders. As mentioned, that system now includes, among other aspects, more than 700 contracted providers, enhanced countermeasures for influenza and other infectious disease, and a medical directive that begins to lay out the path forward to continue the iterative process that allows the system to evolve as required. Our approach to improve care has been collaborative, not just by coordinating with federal interagency partners, but also by building and continuing critical state and local partnerships, collaborating with the Mexican government, and calling upon non-government experts to assist when needed. Several systematic reviews of this developing system have been undertaken in the last year, all agreeing that the approach is sound. We have a legal, moral, and ethical duty to care for those in our custody. The challenge was unprecedented, required an unconventional solution, and we responded. At DHS and across the government, we remain committed to ensuring that individuals, especially our children, receive appropriate medical care. Thank you very much, and I look forward to answering your questions.
I thank all the witnesses for their testimony. I will remind each member that he or she will have 5 minutes to question the panel. I will now recognize myself for questions. Chief Hastings, early last month, ProPublica released video footage of Carlos Hernandez Vasquez, who was being held in Border Patrol custody in May of 2019. And the video shows in heartbreaking detail the last hours of Carlos's life. He was 16 years old at the time. He died in his cell just hours after a nurse practitioner apparently recommended immediate medical care. In fact, his body was first discovered by his cellmate, who was another child who was being held in detention. Understanding that this specific case is still under investigation, what can you tell us about the lessons CBP has learned from this particular case?
So, ma'am, I would start by saying dignity and care of those are of the utmost importance. I'm a father. I have a granddaughter as well. I watched the video. I saw the same video from the media report, and the video itself was troubling. As you know, the case is still under OIG investigation. I can't speak to what their findings are. One thing I can add is that I know that all of the video has been turned over. All the items that we had, the video of all the cells has been turned over to OIG, and they have all the video, not just a piece, as I understand, that was pulled from the Sheriff's Department.
So are you insinuating that there is more, that I'm not sure what you're insinuating.
So, as I said, all of the video that we had throughout the station that day has been turned over to OIG.
And what did it show?
I haven't seen it, ma'am. I just know that we have turned it over and provided to OIG, who's the independent investigator.
So I was just curious about what you were insinuating by saying we just saw a little snippet, but that...
I'm just insinuating we've turned over all the evidence and all the video.
Okay, so broadly speaking, what do you think could have been done differently, without talking about what was done, your review of the case, what do you think could have been done differently? It's been indicated that welfare checks were conducted on this young boy, young teen, but the video shows an increasingly sick Carlos in pain, vomiting up blood, writhing around in pain until he falls unconscious to the floor of his cell. And this happened over a course of hours. So I'm wondering, is there a finding by your internal review that maybe it wasn't understood the level of medical attention that he needed when he was in the cell at that time?
So again, it's ongoing, and certainly any lessons learned from any of the investigations, this investigation or any others, we'll look at to make changes. I can tell you that we did put out guidance to the field that any of those, and I believe this was July, a memorandum from then Commissioner Saunders went out, any subjects in our custody were receiving welfare checks every 15 minutes and being documented in our system of record.
You mean person, not subject in your custody?
Person, yes, ma'am.
Because that's what they are. They're people, not
People, ma'am.
subjects. Can you tell us what policies are in place to ensure that recommendations that you receive from medical professionals are actually followed, and what measures exist to protect healthcare professionals who refuse to clear patients for detention? I mean, I'm assuming that a CBP officer has to stay with any child or human in detention if they go to a health facility. Is that correct?
That is correct.
And are you aware of pressure that CBP officers are putting on medical professionals to release patients so that they can get back to their job at the border or at whatever facility to which they are assigned?
No, ma'am, I'm not. In fact, in reviewing some of the IG investigation material, I saw the contrary, where one of our agents actually asked for additional care and stood up for one of the children that was sick until the fever was down. So we've seen the opposite.
That's a good story to hear, but there have also been indications that health professionals feel intimidated and pressured by CBP personnel to release patients to detention even when it's not medically indicated. And to me, it seems like doctors should be the ones making these decisions, not CBP officers. What policies are in place to ensure that recommendations of medical professionals are followed? I mean, are there policies? I mean,
So, yeah, we have multiple policies, and we work closely with both CWMD as well as our own Office of Support. We have medical staff that we have hired to oversee the contract and to make sure that we're providing the best care we can in the family practitioner model.
Dr. Eastman, it's good to see you again. As the senior medical officer in the Department of Homeland Security, when you make recommendations for the medical care of individuals in CBP's custody, are they followed by CBP?
Nice to see you as well, ma'am. And yes, we work collaboratively with CBP to advise and help implement the recommendations that we offer. In fact, we have our employee, a CWMD employee, is the senior medical advisor at CBP, and this team works collaboratively to implement the recommendations that are made with hearty respect to the fact that there are operational considerations as well.
If you look at some of the cases involved with the children that I mentioned, every single one of them was very, very sick and should have been hospitalized and never released back into CBP custody. So there has to be, I would hope, some effort to review where these mistakes were made, that these children who were very, very sick, one of whom had a temperature of 105.7 when they were initially examined. I mean, I just don't understand how that could even be possible. I mean, are CBP officers trained to, I know they're not medical professionals, but it doesn't take, you don't have to be a doctor to see that a child has a 105.7 temperature. So what?
Ma'am, we do the absolute best we can to provide the best care possible to the children in our custody, but there is not a mechanism for us as the Department of Homeland Security to review the care that's provided outside our system in community hospitals all along the border. And I think
Well, I'm talking about that initial, I mean, it was a nurse practitioner, I believe, who examined Carlos and gave him Tamiflu because that's what he was diagnosed with. But have you recommended flu vaccines for detained migrants?
Ma'am, our approach to the flu vaccine is a comprehensive one that encompasses all of the settings where care is delivered along the southwest border. In fact,
Is everyone given, is every detained migrant given a flu shot?
The Department of Homeland Security's vaccination strategy has resulted in more than 60,000 vaccinations being given, predominantly in the ICE Health Service Corps. Our goal is to give the right vaccine to the right person at the right time.
Have you spoken with the acting secretary about ways to ensure that CBP follows your medical recommendations?
Ma'am, like I said, the direction from leadership, from the secretary to all the acting secretaries I've worked has been the same, to do the right thing for the people in our custody and for all of us to work together to do just that.
I understand. I'm just asking you, and you can just say yes or no. Have you specifically spoken with the acting secretary about ways to ensure that CBP follows your medical recommendations?
Yes, ma'am. Prior to his current role as the acting secretary, we spoke along the border.
And do you continue those conversations?
Yes, ma'am. Absolutely.
Thank you. I now recognize the ranking member, Mr. Higgins.
Thank you, Madam Chair. Chief Hastings, the President requested emergency supplemental assistance to address the crisis at the border on May the 1st, 2019. It took 2 months for that money to be approved by Congress and to get that money to the field to provide relief. Meanwhile, the Department of Health and Human Services ran out of money for unaccompanied minor bed space. Please explain to the committee and Americans watching this hearing the immediate impact that supplemental funding had on Customs and Border Protection operations at the border and CBP's ability to move unaccompanied minors out of CBP facilities and into ones more suitable for children, including professional medical care.
Thank you for the question, sir. So as everyone's full aware, we dealt with 321 total children last fiscal year. Those were both UACs and in families. We have never seen those kind of numbers before. That quickly overwhelmed the entire system. Specifically, in May and June timeframe, 144,000 apprehensions in May or arrest, inadmissibles as well. The system got backed up. We were still processing in about, on average, 25 hours per average per UAC, but the UAC couldn't move. HHS was out of funding, they were out of money, and they were telling us they couldn't move those in our custody. By law, there's nothing more we can do with the UAC either, other than turn them over to HHS.
Thank you for that clarification. And in the interest of perspective for the American citizens viewing this hearing and for my colleagues on committee, let me just say that there's been an undercurrent of insinuation that Customs and Border Protection has in some way been neglectful to caring for children. And I believe we all accept that the medical facilities of the United States of America, the hospitals of America, will provide some of the finest care in the world, arguably the finest care in the world. And we'll investigate any death of any child that's in the custody of Customs and Border Protection, and those deaths should be investigated. And every loss of a child is tragic, and we should take a deep breath and look at that. But for the sense of perspective, let me say that in 2017 alone, 28,308 juveniles died in professional medical facilities in the United States of America. Many of these children arrive at the border, they're very sick. They're struggling, no telling what they've been through. CBP does their best to take care of them, but tragically, sometimes children die, including 28,308 children in American hospitals in 2017 alone. Those are government numbers from the CDC. In our juvenile detention facilities, it's not uncommon historical data from the government. We show an average of about 10 deaths in a 6-year period. These are juveniles in juvenile detention facilities in America. Much better designed and equipped to care for the children in their custody. The men and women that wear badges care about the children that come under our care. I lost my firstborn daughter in a hospital. I lost many more on the street. Children in my arms, a young teen hit in the head by an axe handle over an unpaid drug debt. I sat there in that dark street and held that young man's head, whispering prayer into his ear as a lifelight led his life. Infant child, unresponsive, hysterical parents. I did my best to perform infant CPR to resuscitate that child. She didn't make it. Dr. Eastman, in my remaining 25 seconds, sir, please respond to the spirit with which Customs and Border Protection addresses any sick child that comes into our custody.
In my experiences, sir, CBP officers, Border Patrol agents, they're law enforcement officers, most of them are parents as well, and they act exactly as you described to do the best they can under the circumstances they're dealt.
Thank you, gentlemen, for appearing today. This is a painful and necessary hearing, and I thank Madam Chair and the Chairman of the whole committee for allowing us to discuss how we can improve the care for our children that come through our border. And let us not forget that that we must operate based upon the cornerstones that have defined America as we attempt to care for all of our children. So I thank you again, Madam Chair, for holding this hearing. I yield.
Apropos of that, Mr. Hastings, would you, I'm sorry. Apropos of what my friend Mr. Higgins was asking you, would you agree that taking $3.5 billion from a military counter-drug program would be problematic? Because there's reporting today indicating that the president is planning to divert $7.2 billion in Pentagon funding to build his wall. Would you find that to be problematic in terms of addressing the issues that you testified about?
So, ma'am, I would also add, though, on the other hand, we had a very large influx of families and children. We also had an influx of single adults. We saw those numbers go up. And I would also add that we had 147,000 gotaways that we know of last year. So we have not only asylum seekers turning themselves in, but people trying to elude as well. And this is a whole of government approach to many things that we need to protect and safeguard our borders.
And do you think taking $3.5 billion from a military counter-drug program would be a problem to address the issues that you're yes or no?
We need border wall, I can tell you that.
I didn't ask you that. Can you answer the question I asked you?
Can you ask the question again?
Sure. Do you think it's problematic that the president wants to take $3.5 billion from a military counter-drug program?
I think I would say...
Is there a reason why you can't just say yes or no?
No, I don't.
So you don't think that's not problematic?
For our needs, there are needs that we have on the border as well to secure our border, and wall construction is one of those.
I now recognize Chairman Thompson for 5 minutes.
Thank you very much, Madam Chair. The title of our subcommittee hearing today is Assessing the Adequacy of DHS's Efforts to Prevent Child Deaths in Custody. My comments talked about one death in custody is too much. I understand that since the deaths have occurred, there's an interim medical directive that talks about that we'll no longer do medical assessments for children under 18. Are you familiar with that, Mr. Hastings?
Sir, our new policy that just went into effect is we're doing health interviews for all of those less than 18, and we're doing health assessments, which is basically like a physical for all of those 12 and younger, or anyone who says that they have a health condition or a medical issue.
So, Dr. Eastman, are you familiar with that
Yes,
policy?
Sir. Yes, sir, I am.
Explain it a little bit for the committee.
Yes, sir. CBP uses a phased approach. The first, to meet the medical needs of the population in our custody. The first phase involves recognition of illness and the encouragement of migrants to report to us that they have an issue. The second phase is a health interview that's been standardized across Customs and Border Protection using a questionnaire able to be administered by a law enforcement officer, but developed in concert with experts at the CDC and across the government with a twofold purpose: to identify an emergent medical condition, but also to identify the potential of an infectious disease that might harm the migrant or threaten the United States. And the third phase of that approach is a medical assessment from a qualified provider. That medical assessment in the final medical directive is given to anyone with a positive finding on the health interview, or to any child under 12, or to anyone who requests it. I have to also add, sir, just 1 second, the last phase of that care plan is for any true world emergencies, someone that would need cardiac care. We're obviously utilizing the local healthcare system where the migrants are.
So why would you determine 12 as the cutoff for an assessment?
Yeah, so the way the directive was derived was a collaborative approach from all of us involved, from DHS and CBP and the other experts. And the way the directive was approached was felt that a teenager would be able to seek and request medical care when necessary.
So what outside groups did you talk to when you did this assessment?
Yes, sir. We have incorporated advice from the Assistant Secretary for Health, as I mentioned, several members of his staff who are seasoned pediatricians. In addition, we worked with a number of public health service officers along the border who helped give us, who are pediatricians themselves, with vast experience in everything from disaster response to responding to Ebola. In addition, we hired a senior medical advisor for pediatrics, an outside pediatrician with vast disaster experience to come assist us. And we continue to listen to the groups that are involved in the care, including the American Academy of Pediatrics, family practitioners, and other organizations who have given us advice on this topic. We continue to utilize that advice to form our policies and procedures.
Well, I'm happy that you mentioned the American Academy of Pediatrics. Madam Chair, I have a letter from the American Academy of Pediatrics that says there's no medical justification to only assess children younger than 12. And so I want you to seriously consider the group you talked about, because they're the one that's dealing with children. And they're saying 12 is not a magic number. And some of us are concerned that between 18 and 12 is a vast shortage of opportunity for us to help children that we're talking about here today. I just want to put that in the record, Madam Chair.
So received.
All right. So, Mr. Hastings, why did it take the department as long as it did to revise this directive? Are you familiar with that?
So we did put out an interim directive immediately in December, and then we worked with these various components, as was mentioned earlier, internally and externally, our stakeholders, to make sure that we got this right. But the interim policy was in effect since December of 2018. And additionally, we didn't wait to take actions. We were taking many other actions, including increasing our contract personnel even before that.
So are you familiar with the clauses subject to availability of resources and operational requirements in that directive?
I'm resources and obligations?
Resources and operational requirements.
I'm not sure what you're referring to, which parts are.
Same directive you talked about that's been developed.
Well, one thing, so we need funding, and it does mention funding in there to continue our assistance with resources is funding, basically, to continue the assistance with our contract medical providers.
So who makes decisions as to whether resources are available?
It's based on budgetary need. The other thing.
So who makes that decision?
So if we continue to receive funding to provide the current services contract services, will continue to do this.
Do you make the decision or who?
Sir, we have to be funded to continue for one
I'm not talking about. I'm saying who makes the decision, what individual, in the implementation of this directive?
So as I said, we've implemented the directive. When we would have had difficulty, what you're referring to, in staying with the directive would have been very difficult when we were backed up and had 7,500 children.
So when you said we, is that you?
That's the Border Patrol.
So who at the Border Patrol makes that decision?
We would make it operationally and provide a heads up to congressional.
So there's no individual by name that you can give this committee?
Sir, we constantly brief what we have going on the border as far as the amount of numbers we're seeing and the resources that we're using down there. We consistently brief up what we're seeing on the border and the situation, and throughout the crisis, we continue to brief those numbers. We were overwhelmed, is my point.
Well, but I'm talking about the directive. I'm not talking about the conditions. You put a directive in place.
We have.
And you said subject to the availability of resources and operational requirements. And I'm asking you, Who makes that determination? What individual?
So we will continue to do that. I would imagine that would go to the highest levels. That would probably go to the chief or the commissioner to stop something as important to this, and we would certainly notify other entities if we were forced into a situation, overwhelmed, or not budgeted for this. We would certainly notify.
I am having real difficulty you not giving us a name. I mean, it's not a got you question. You got a requirement that you pushed out. Someone has to be responsible for making decisions on that requirement. And I'm just asking for my sake, and I hope for other members of the committee, who that individual is.
It would be the chief in consultation with the commissioner. And we would advise, like I said.
Now, is that you?
No, I'm not the chief of Border Patrol. I'm the chief of operations. I oversee all the operations in the field.
So the chief of Border Patrol would interpret the policy we're talking about now in terms of resources and other things.
When we did not have the resource to fulfill that obligation, that's what you're referring to, I believe.
No, I'm talking about the new policy that was put in place in response to the death of the children. And it said that it's subject to the availability of resources and operational requirements. And I'm just trying to get a sense of who's in charge of making those determinations.
So we have to be properly resourced to be able to carry this out with our contract employees. We have to be properly we have to have the proper funding to do that. Operationally, it would be the chief and the commissioner that would pass this down in close work with the field commanders and the chiefs in the field.
Well, Madam Chair, I think my problem is we've had a problem and we've had some proposed solutions, but I'm not comfortable with who is responsible for carrying it out, to the point that we might end up with another situation because the directive is unclear and subject to anyone's interpretation. I'm just trying to make sure these problems don't happen again.
Gentlemen, yield for 10 seconds.
Be happy to.
Thank you, Mr. Chairman, Madam Chair. I believe that our witness is attempting to answer the question to the best of his ability. That you're asking for one name, and the answer is that there are many names. Chain of command is a multitude of men and women that will make these decisions on an operational basis based upon what they're dealing with in the field at that time, and their report up chain and down chain. So the answer is not one name. Ultimately, the gentleman referred to at the highest level is responsible, but the implementation of a new policy will be based upon the work done throughout the chain of command. So it's many people, it seems to me.
Well, you didn't help either with the response. So I am still, for clarity's sake, if we come up with a new policy, Madam Chair, and we might just have to follow up with some subsequent language requests. But I think it's not unreasonable if a policy is put out on an issue this critical for us not to have those individuals who are tasked with the responsibility of making sure they carry it out. So I yield back.
Thank you. The gentleman from Pennsylvania, Mr. Joyce, is now recognized.
Thank you, Mr. Chairman, Madam Chair, Mr. Ranking Member. Dr. Eastman, in the fiscal year 2019, more than 200 large groups of 100 people or more, often of various ages, arrived along our southwest border. Many of these large groups arrived during the height of the flu season and during months of intense high heat. Can you give an estimate of how many of these migrants likely arrived at the border with a pre-existing illness or infectious disease in fiscal year 2019?
On an individual basis, most of the migrants we saw overwhelmingly were well, but there were notable cases that were not. I'll take that back for the record to try to get you a more exact number, because I think, we've got that data. I don't have a specific number at the fingertip, but mostly, overwhelmingly, they were well. But your point is exactly accurate, that folks are coming to us after a long journey, many of them with the flu or another infectious disease that needed to be addressed.
For those who were traveling hundreds of miles to our border, what was the likelihood that they had access to medical treatment along their journey?
Sir, I'm not the expert on the care that occurs from prior to them reaching, our southern border. We have worked collaboratively with the government of Mexico to try to, help them do everything they can to improve conditions on the Mexican side of the border. And I know the department has a number of efforts in Central and South America to facilitate other parts of this, but I'm certainly not the expert on what happens prior to the migrants reaching our border.
Thank you. You mentioned that potential infectious diseases have been with these migrants as they presented to our border. Can you tell us more about that, please?
Yes, sir. Predominantly what we've seen is seasonal influenza. We've also seen sporadic cases of tuberculosis, chicken pox, or varicella zoster virus. We've seen some mumps. We, knock on wood, I'm superstitious and hesitant to say this, we have not seen a case of the measles, but those are predominantly the diseases that we've seen.
In contrast to children who have presented with grave illnesses, can you tell us how many children that you estimate have been saved by the medical attention provided under the United States government custody?
So that number is a difficult one to pin down directly, but from the beginnings of my work along the border, we know that about 10% of the migrants that come across will end up going into the medical assessment process. Again, those are rough, very early numbers in the crisis. How many were saved directly, I can't pin down. It's hard to predict, but there are certainly lives that have been saved by the response to this crisis.
Dr. Eastman, continuing, during this crisis, CBP received medical surge assistance from interagency partners like the United States Coast Guard medical teams and personnel from the United States Public Health Service. How important is having additional medical staff on site at CBP facilities?
It's important to remember that, CBP is a law enforcement organization. We think that healthcare is best provided in healthcare settings. However, by virtue of the unprecedented crisis we faced, we had to mount an unprecedented solution. And that care that was initially, assessment and care that was initially provided by our first responders, the Coast Guard, by our intermediate responders, the Public Health Service, and then now subsequently that's placed onto the backs of CBP's contracted medical providers, that care is vital. It's vital because we've got an unprecedented problem in the system, and that's a very unconventional solution. I know of no other law enforcement agency that I've ever interacted with or heard of that has such a developed healthcare infrastructure inside it.
So in face of this unprecedented crisis, you have been able to provide vital health care. Is that the message that I'm hearing from you, sir?
Well, I wouldn't say I would say we. This has been a collaborative interagency approach. And at the heat of the crisis, I spoke to Admiral Jawar and the chief medical officers of the Coast Guard who have changed hats recently, but I spoke to them daily. And we, the department, received help from them and many other entities to provide what is clearly an unconventional solution to this unprecedented problem.
And we thank you for doing that. Thank you both for coming here today, for testifying in front of us, and I yield the remainder of my time.
Thank you. The gentlewoman from New Mexico, Ms. Torres Small, is now recognized for 5 minutes.
Thank you, Madam Chair. Thank you, Mr. Ranking Member. And thank you, Chief Hastings and Dr. Eastman, for being here today. In December of 2018, Jacqueline Calmaquin and Felipe Gomez Alonso died while in CBP custody after being detained in the district that I represent. And subsequently, the DHS Office of Inspector General opened an investigation into their deaths. 3 months later, in this committee hearing room, former Secretary Nielsen testified that she directed the CBP's Office of Professional Responsibility and the Inspector General to work as quickly as possible to complete these investigations. Then, in May of 2019, my colleagues and I again urged the department and the Inspector General to complete the investigations in a timely manner. The OIG responded to our request, saying it was working to complete the investigations as expeditiously as possible. But it was only last month, nearly a year later after these tragic deaths, that the investigations were completed and provided to Congress. Even more concerning, the OIG limited its investigation scope to only determine whether there was malfeasance by personnel and did not consider whether CBP's policies and procedures are adequate to prevent migrant child deaths. As I've said from the beginning, the reason for these investigations is not to punish people. It's to keep this from happening again. It's to make sure that we have the protocols in place in case we're faced with this challenge again. It's the committee's understanding that the investigations did not even interview medical professionals outside of the offices of the medical examiner and the department. This is unacceptable, especially given the significant number of family units and unaccompanied children that traveled to the southwest border last year. Now, Chief Hastings, I deeply appreciate the work that the men and women of Border Patrol do every single day and have done in the past year to mitigate the situation we saw at the southern border. And I want to find out whether the policies and procedures of the agency are setting our agents up for success to keep migrant children safe. So, Chief Hastings, has CBP received the full reports of these investigations?
I have not seen a full report. I've seen an abbreviated report from our Office of Professional Responsibility.
Thank you, Chief Hastings. That's deeply concerning. The committee was told by the OIG that CBP has received the reports. So that's something we will follow up on.
I have not personally. I have not.
From the information that you received, have you identified specific lessons learned that CBP took from the reports and have recommended protocol changes to enforce them?
So I think one of the lessons learned is we needed a standardized health form across the board for all of CBP. One of the things that we saw, there were multiple forms being used in the field throughout this entire year. That is now standardized.
And you have the updated form?
Yes, ma'am.
Okay, any other lessons?
That is one of the bigger ones. You visited the location where we lost Jakelin. You're well aware of the remoteness and the amount of time it would take to get even our own agent out of that area. So I think you're very well versed with the issues of remoteness and rugged terrain that we had out there, as well as transportation. We have also added a large transportation contract, buses, and many other things to help get folks from the border.
Thank you. That's a great lesson learned, and it's certainly something I saw, so I'm pleased that Border Patrol is addressing that. Do you have multiple buses now under contract?
We do, and under contract and our own personal that we have purchased vans and buses, as I mentioned earlier.
What about pediatric equipment? One of the lessons learned for me with Jacqueline's passing is not having the appropriate cuff to take her blood pressure. Is there pediatric equipment across the board, along the border, that's available if necessary?
So we dedicated a large portion of the supplemental funding to our EMTs. We have over 1,500 EMTs in the field, and we have since updated them with equipment and made sure that they have everything to meet their daily needs.
And that's also part of protocol, so it's required, and if there's a deficiency, an agent has the ability to alert to fill that deficiency?
That's correct.
Thank you. I want to shift now to preventing the spread of infectious diseases in CBP stations. Chief Hastings, what are the protocols that CBP has in place to protect both migrants and CBP personnel from the spread of infectious diseases, such as the flu, inside Border Patrol stations, processing centers, and ports of entries?
So with our contract personnel that we have in all 9 southwest borders in about 40 locations, put those personnel based upon the highest vulnerable populations, highest flow that we were seeing, as well as the least amount of medical assistance in the general area. That's how we decided where to put them. They are fully trained and are able to care and provide any type of antiviral flu and do flu testing. They're able to do that. They're able to do acute care and other things that aren't referred to secondary care.
And you have written protocols that support that need?
Can I help, Chairman?
Just yes or no, because I'm out of time.
Yes, ma'am, absolutely,
Yes,
we
if
do.
you can supply those to supplement the record, I'd appreciate
We'll
it.
work to get that to you, yes.
Thank you. And my time has expired, thank you.
Thank you. We now recognize the gentleman from Mississippi, Mr. Guest.
Thank you, Mr. Chairman. Chief Hastings, want to speak to you on the overall immigration crisis that we have and are currently experiencing along our southwest border. I note on page 7 of your written testimony, you refer to fundamental flaws in the immigration system. You go on to say CBP has pleaded with Congress to address the layers of existing law and judicial systems that adversely impact our ability to effectively manage our immigration system. There are 3 key gaps in our legal framework that Congress has yet to address. And you list there the Flores settlement, the TVPRA, and the asylum assertion. And could you just take a few moments to expand on each of these factors that you've listed there in your report and how it impacts your department's ability to secure our border?
So we need the ability under Flores, we need the ability to be able to hold in a setting that is fair, and it provides fair and expeditious immigration proceedings. Flores is a major issue for us, completing that under the current 20-day process that's required. When we released over 149,000 families, when we were interviewing these individuals, they literally told us that we were told, bring a child and we will be released. That's what is encouraging this large flow that we continue to see. We believe that they should be housed in an FRC together with all of the adequate things that have been provided, medical, dental, pharmacy, education, all the many other things. The double standard for non-contiguous UACs, being able to return a UAC to Guatemala, Honduras, other countries like we are currently with Mexico and Canada. That would assist with the large number of UACs that we're seeing across our borders today. Another, again, a vulnerable population. And lastly, tightening the asylum bar to the low asylum bar for credible fear as we see the massive backlog of over 1 million cases right now.
And would you agree, Chief, that if Congress were to address these 3 issues that you have set forth in your report, that it would help stem the flow of illegal immigration that we've recently seen across our southwest border?
Yes, we believe it absolutely would.
And Chief, you were asked a question earlier about moving or the shifting of money that was designated for the Department of Defense to our southwest border for the purpose of border wall construction. Do you feel like that the construction of the border wall system has improved your agency's ability to protect our homeland?
Absolutely. So again, a border wall system is more than just a wall. It comes with technology, comes with roads, gives us situational awareness, gives us time, impedance and denial, and time to respond. I've seen it work personally in the many areas I've been in the field. I've seen what it does for us, and I strongly support it.
Thank you. And just lastly, Chief, is there any other recommendations that you would make to this committee as to how we can better help your department, again, to secure our homeland, and then those individuals that are within our custody, that we can do our best to make sure that they are protected and receive the care that they need?
Just would request if we're not coming to an agreement on some of the recommendations we've gave, that we continue to fund HHS. And so we can move those UACs through the cycle and get them into the proper environment for care. Would also request assistance with ICE funding as well for single adult bed space, because that's another demographic that we see backing up in our facilities at times, and ICE needs proper funding for single adult bed space.
Chief Hastings, thank you for your service to our nation, and Madam Chairman, I yield back.
Thank you. I now recognize the gentlewoman from New York, Ms. Clark.
Thank you, Madam Chair, and I thank our witnesses for testifying here before us today. Chief Hastings, last year you testified before the Judiciary Committee, and my colleague, Congressman Liu, asked you whether a 3-year-old girl could pose a criminal or national security threat, and you responded, I don't know. I think attitude goes a long way in addressing the multitude of issues that you have before you, but specifically preventing child deaths in custody. And I believe that we shouldn't be surprised when children don't receive medical attention they need, particularly when we don't know whether a 3-year-old could pose a criminal or national security threat. Having said that, last fall I introduced H.R. 3777. It's the National Commission to Investigate the Treatment of Migrant Families and Children Act, which would create an independent commission to study issues like family separation, as well as the death of children in CBP custody. But short of passing my legislation, we have to rely on the Inspector General to get to the bottom of these matters. In a report recently released by DHS OIG, it states that a Border Patrol supervisor had to pay out of their own pocket for an over-the-counter medication for an 8-year-old Felipe because Border Patrol's insurance did not cover it. In addition, the CBP EMT was unable to take a blood pressure of Jacqueline, age 7, because they lacked a pediatric cuff. What steps have CBP taken to ensure access to basic medical necessities and equipment across the southwest border?
Ma'am, thank you for the question. So we did indeed see an issue or a problem with us being Border Patrol or CBP, OFO being able to fund non-prescriptions, over-the-counter prescriptions. We have since fixed that. We have a contract through ICE to be able to purchase any needed over-the-counter remedy that is prescribed. So we have that. And then additionally, as I mentioned earlier, thank you for the supplemental funding that we were able to provide much needed and equipment for our EMTs out in the field. So those have been fixed.
Wonderful, I appreciate that. But, you know, in the decade prior to 2018, there was not one single child death in custody. So I'm a bit concerned that, you know, there just seems to be a callousness taking place. I'm glad that we're focused on this. However, if we're able to shift funding for a border wall, we should be able to shift funding to save human lives, particularly the lives of children. And we need to understand what went wrong in 2018 and 2019. If a CBP official failed to take reasonable steps to prevent the death of a child, what kind of disciplinary measures do you think would be appropriate?
Ma'am, I haven't seen any negative, anything.
I'm just asking, hypothetically.
I would have to see everything that went into the report. I'd have to see the specifics. But if it was negligible, we would certainly take immediate action.
That's good to know. Has any CBP official faced accountability for the death of children in custody?
No, ma'am. There's been no negative findings of malfeasance.
All right, no problem. How does CBP determine what expenses qualify as consumables or medical care?
How do we determine, I'm sorry, I didn't hear you.
How does CBP determine what expenses qualify as consumables or medical care?
Ma'am, let me help Chief Hastings with that. We use
Sure.
the MedPAR system, which is actually administered through ICE. It's the DHS system that pays for care for migrants in our custody.
Okay,
in addition to that,
could you, hold on one second, could you just provide us examples of the types of projects or activities for which consumables and medical care funds have been obligated or expended since the supplemental was enacted?
Absolutely, ma'am.
Sure.
And again, thank you for the supplemental funding. In response to that, at our more than 40 locations that now have contracted medical support, they have a standardized formulary of medications and equipment that's used to care for the migrants in custody. So that is a clear example of how money's been appropriated from the supplemental to help further the care of children in our custody.
And how is that replenished? How does the subcontractors, are they?
Yeah, the contractor, I'm not an expert in their supply chain management, ma'am, but they have a system that replenishes those, and again, the supplemental pays for that.
Very well. Madam Chair, I yield back the balance of my time.
I now recognize the gentleman from California, Mr. Correa.
Thank you, Madam Chair. And gentlemen, thank you for being here today. I'm a member of both this committee as well as the House Judiciary Committee, where we've had numerous oversight hearings concerning the dangerous detention facilities, adequate standards of care for migrants, including young children. And like my colleagues here, I'm troubled by the multiple reports of overcrowded facilities. I've actually toured some of those facilities. And there is a general agreement that CBP Your facilities were not meant to handle the influx of children and families that we've seen over the last 2 years. So my question is, what contingency plans does the department have in place to ensure the safety of those within your custody?
So, sir, there are a couple things I would add. As I mentioned in my opening, we
Yes,
have
sir.
6 off-sided facilities with complete wraparound medical, food services, shower, pretty much all amenities. And then additionally, we've planned long-term to put central processing centers up in our busiest areas, primarily the Rio Grande Valley, the El Paso sector, and the Yuma sector. Those are modular buildings that are being completed now or will be completed and started in the spring for Yuma. But they're actually being completed right now for El Paso. So in other words, having those facilities and those wraparound services is something that we're planning for now, and we have a long-term solution.
Mr. Hastings, I know you're chief of operations, but if it can pull back a little bit, when General Kelly was the Secretary of Homeland Security here in this committee, he testified, and I'm going to paraphrase him, that border security goes beyond our border. And I'm thinking to myself, you don't wake up one morning and say, oh my gosh, look at all those folks at our doorstep. I have to imagine you coordinate with other agencies in the federal government, with other governments, and begin to see that flow of refugees, that flow of migrants moving. And so my thought is, how do you prepare? Or are you preparing for those ensuing waves of refugees that are coming not only from south of the border, not only from Central America, but other parts of the world? I don't see this as a one instant phenomena, but rather as the world areas of conflict continue to escalate, as you have folks in harm's way. This is going to continue to be a challenge, migration, refugees from around the world. Are you doing anything to anticipate these kinds of situations, near future, long term?
Yeah, so we're embedded with multiple different governments, work closely with the Northern Triangle and have agents on the ground down there working with them now. Also work very strongly with our Mexican law enforcement partners as well on a day-to-day basis, the chiefs in the field.
Let me ask you something.
Sir, may I just add something?
Yes, go ahead, Dr. Eastman.
In addition to what the Border Patrol does, the National Biosurveillance Information Center, which is a CWMD entity, with the chief medical officer, works continuously with our partners, not just Mexico, but our partners south of the border and worldwide, to identify and begin to recognize and counter health-based threats to the United States. That's part of the package.
A little while ago, my colleagues talked about the flu vaccinations, and essentially your response, I believe, and you confirm this or not, operational challenges have prevented you from really vaccinating a lot of those individuals that need it? Yes, no?
No, sir, that is definitely not my response. And just to be clear,
What is your response, sir?
Our approach is comprehensive. There are migrants who have come into the United States custody that have gotten vaccinations, including and up to this entire CDC catch-up protocol at HHS. We've administered more than 60,000 independent vaccines, predominantly in the ICE Health
So
Service.
you're moving in that direction, and this discussion we've had of independent doctors volunteering to get you up to speed to get there, that's not a factor? You couldn't use them, or you're doing fine on your own?
Medical volunteerism is a challenge to medical organizations, not just ours. And we have, because of the difficulties in utilizing volunteers and the difficulties with licensure and administration, we've actually encouraged them to volunteer in the local government shelters, and CBP that has some, and both CBP and our office have done work to try to vector those volunteers into places that can utilize them more easily than
I'm running out of time, Madam Chair, but I'd like to follow up on this issue of the challenges of having licensed doctors integrated into your system of actually being able to vaccinate some of these children and deliver medical services that maybe CBP is not able to deliver because of limited capacity. And finally, Madam Chair, if I can get 30 seconds, Dr. Eastman, you talked about, you made a statement that Mexico is trying to improve on their side of the Mexican border some health care. Are we coordinating it all with the Mexican authorities in terms of making sure that health care, disease does not respect the border, but rather it addresses both sides. So are we addressing both
Absolutely,
sides of the
sir. We
border?
made a visit, the chief medical officer made a visit to counterparts in Mexico City last year. We continue the dialogue and we continue to work together to make this situation as good
And
as
finally,
possible.
Madam Chair, if I can, I'd like to have written testimony on that later on for review.
We'll take the questions for
Thank you
record.
very much,
You bet.
and thank you, gentlemen, for being here today.
Thank you, Mr. Correa. I now recognize the gentleman from Texas, Mr. Green.
Thank you, Madam Chair. I greatly appreciate the opportunity, and I thank the witnesses for appearing as well. To both of you, do you take the president seriously when he makes comments?
Sir, I don't, what comments are you referring to? I generally,
He's our president. You hear his comments.
when we receive, I don't know what you're referring to.
Well, about the wall.
I think the wall works from my experience, from what I've seen it do in the field firsthand.
So you take him seriously then,
On the wall,
on the
the
wall.
wall works.
So you think Mexico should pay for the wall?
Sir, all I can tell you is the wall
You take the
works.
president seriously, don't you?
I can just tell you that I know the
The
wall
president
works.
said Mexico should pay for the wall.
I'm not involved in funding the wall. I'm just telling you that the wall.
Well, you take the president seriously. Let's go on. How many lives would the wall have saved?
I don't know the answer to that question, sir. That'd be
I see.
speculative.
Well, let me ask you this. Are asylees criminals?
Or the what? I'm sorry, sir.
Are the people who seek asylum criminals?
People who cross the border illegally.
I didn't ask you about people crossing the border illegally. You know what an asylee is, do you not?
We have people that.
Do you know the definition of asylee?
I do. Per the CBP.
Then my question is, are asylees, people who are seeking asylum, asylees, are they criminals?
We are asking them to go to a port of entry to proceed.
That has
lawfully
little to
across-
do with my question, sir. My question is, are they criminals? Why are you evading? Why will you not state what you know to be the truth?
If
Why are
they
you
cross
doing
the
this?
border illegally, if they've committed a crime.
Are asylees, people seeking asylum, criminals?
Again, if they cross the border illegally, it is a crime.
Where do you find this in the law to support your position that people who are seeking asylum are criminals? Are the babies criminals? This is why you treat them the way you treat them? You perceive them as criminals? Babies aren't criminals. They have no malice or forethought. What would you recommend we do to prevent future deaths?
As I've discussed, sir, we're taking a lot of those actions and have been taking those actions for quite some time. I think we're taking the right steps now to prevent further deaths. It will be difficult, as we've explained, to say we're going to prevent every death. The people that we encounter on the border, many of whom have traveled over 2,000 miles or more, some have never seen health care, some have never had treatment, some may not have eaten or drank anything, but we're running into them obviously many times in their worst condition and worst case scenario, and we're doing everything we can to get them immediate treatment and aid when that's the case.
Again, what can we do, meaning Congress?
As I mentioned earlier, I think taking some of the actions for the double standards for non-contiguous UACs, that is one, to quit drawing UACs up to our border because we're unable to return them unless it's Mexico or Canada. And then I think, as I mentioned earlier, the Flores fix, being able to hold everyone together, the entire family, in the proper setting while they go through their expeditious hearing.
for edification purposes, UAC, I find to be a pejorative.
It's in the law and TVPRA.
I understand, but I still find it to be a pejorative. These are children, UACs. Madam Chair, I'm going to yield back the balance of my time. Thank you.
Thank you. I now recognize the gentlewoman from Illinois, Ms. Underwood.
Thank you, Madam Chair, for holding this hearing to continue this committee's important oversight work on the humanitarian situation at our southern border. During my 3 oversight trips to the border last year, I saw and heard firsthand about the need for resources to improve medical record keeping. As a nurse, I know how important clear record keeping is when it comes to both patient outcomes and ensuring healthcare providers can most effectively do their jobs. In response to what I saw at the border, I'm so proud that we passed bipartisan legislation last year to provide CBP with an electronic health record. And just a few days ago, President Trump signed an appropriations package that included $30 million in dedicated funding for that electronic health record. Dr. Eastman, as a physician, can you tell us more about why EHRs are so important to your work at the border?
Yes, ma'am. Thank you very much. And again, thank you for passing the funding we need. EHRs serve a very specific function. They not only allow us to effectively document the care that's provided, but they also allow us easy access to the data to do things like quality assurance. It ensures that we're able to measure the care that we're providing. It ensures that we're able to assess the quality of that care, and it ensures we're able to learn lessons from that. In addition, an EHR system that we intend to develop will improve our ability to conduct disease and health disease surveillance using artificial intelligence techniques that will trigger the presence of potentially of an infectious disease before a human being could pick it up.
And again, from your perspective as a medical provider, how do EHRs help providers better communicate about patient care?
Yes, ma'am. So electronic health records, they're a complicated topic, but they allow us to describe the care that we've provided from the point of apprehension to the point of release from our custody. Not only internally, they don't only help us communicate internally across multiple settings, but they also allow us to communicate to external partners. And one of the things that I think is important in this hearing to mention is that the system that's provided not only protects migrants, the system that has been put together, it also protects the integrity of the healthcare systems in local communities, that were we not absorbing some of the blow, some of these local community healthcare systems would be overrun by the amount of care that's required.
ICE and ORR already have electronic health records, and we know that DHS has already begun the process of building one for CBP. Along with the dedicated funding, Congress directed DHS to come up with an implementation plan for this EHR within 90 days. So Dr. Eastman, can you give us an update on where DHS is in this process and what specific actions have been taken so far?
Yes, ma'am, I can. We are right now we're in the process, sort of the first phase of this, which is to identify some immediate solutions that can integrate the existing technology that's out there. That work is ongoing immediately. We're also working to plan for the long term. And we've hired a chief medical informatics officer who we think has the talent and the expertise to help us build a system that will not only create an effective, customized solution for us, but will harness our ability to help our operators do their job more effectively. Everything we do has to take into account the effects that it has on the individual operator who's doing the job at the border, at processing centers, and in ports of entry along the border.
So then what's next? What are the next phases in the implementation of this EHR?
The next phase is we work our fingers to the bone to try to get this plan together to come back to brief you in 90 days as to where we're headed.
Excellent. So you mentioned you hired this informatics officer. What
Yes,
date
ma'am.
were they hired?
I'm sorry?
What date were they hired?
Oh, I'll have to take that as the specifics as a question for the record. He's been around 5 or 6 months.
Okay. And in your medical opinion, why is it so important to ensure CBP's EHR is interoperable with those used by ORR and the other DHS components?
Thank you, ma'am. Again, we want to make sure that we're able to provide a seamless picture of all the care that's provided from the point of apprehension to the point of discharge. It's important for a provider at ICE to know what happened upstream of that when the person's for the care that's provided in the Border Patrol. Now, that being said, we're working hand in hand with the Border Patrol to make sure that the solutions that we craft together not only accomplish the goals of the EHR, but also are user-friendly and don't add to the processing load, the time that the operators have to put forth to take care of the migrants in our custody.
Well, I appreciate those operational benefits, but the other benefit of an electronic health record is obviously saving lives. We're not missing information, we're not losing patients, and we're not missing opportunities to identify infectious diseases or changes in current status. We're heading into another flu season that's projected to be severe. Dr. Eastman, you noted in your testimony that you are working with CDC, ASPR, and other public health agencies to improve CBP's response. So what specific steps has DHS taken to strengthen its ability to respond to flu outbreaks at the border during this current flu season, which we know has been particularly harmful and deadly for children throughout the United States?
No question, this flu season, according to the CDC and other experts, appears that it may be rough. We have worked hand in hand with CBP to help craft enhanced flu control measures that were crafted with input from experts from the CDC when they performed a 3-phase assessment along the border very early on in the crisis. In addition, we've helped provide CBP with the ability to rapidly diagnose and treat the flu in our facilities at CBP. Again, that capability is present now in over 40 facilities along the southwest border, and I would challenge folks to find another law enforcement agency that diagnoses and treats the flu on the law enforcement side, not the custodial side.
And Madam Chair, if I may, just one last follow-up. What date? Was it new for this flu season that rapid capability has been deployed? Because it's not our committee's understanding that capability was present last year. So
that's been developing all along through the course of 2019. So it's as the contract support has been developing, that flu capability has been put into place, continuously over the years.
Okay, thank you so much, Madam Chair, and to our witnesses for appearing today. I yield back.
Thank you, ma'am.
Thank you. I ask unanimous consent that Representative Jackson Lee be permitted to sit and question the witnesses without objection. I now recognize the gentlelady from Texas, Ms. Jackson Lee, for 5 minutes.
Madam Chair and Ranking Member, thank you very much for this important hearing, and let me thank the witnesses for being present today. And I think it is very important. Mr. Hastings, let me just be clear that you handle law enforcement operations covering both U.S. Border Patrol and Customs and Border Protection. Is that?
No, ma'am, just Border Patrol.
All right, so this is a slight typo. It has you in both positions, and you're not. Just wanted to clarify that for the record.
Just Border Patrol, ma'am.
All right. Let me just, for the record, take note of the fact that the number of children that died in 2018, that in fact, no child had died in CBP custody for the entire decade before 2018. And we lost, in particular, Jacqueline, Felipe, and a number of children that proceeded to get medical care and who were detained and placed in CBP, and ultimately 4 migrant children passed away while in or shortly after being released from federal custody. Would both of you, whether you have children or not, or are around children or around relatives, acknowledge that the death of any child is a crisis and tragic? Mr. Hastings?
Ma'am, as I said earlier, I'm a father and a grandfather, and it is a tragedy.
Dr. Eastman?
Ma'am, I'm a parent, and the death of any child is devastating. But I think it's important to not only note that it's not just devastating to the parents, but I was in our facility in Lordsburg, and I went and sought our personnel who tried valiantly to save Jacqueline during her, and despite their best efforts, they weren't successful. That is brutal on the caregivers as well.
Well, you go right to my point, that dying in the custody of individuals who are basically law enforcement, but seeing when they are basically committed to defend and protect alongside of their immigration responsibilities, their chief responsibilities, that is both a crisis and tragic. For them to have died in federal custody or having just been released. Is that your opinion?
Ma'am, the death of any child, or any person in law enforcement custody is tragic. And as you know, law enforcement officers across this country take very seriously their responsibility that when we place our handcuffs on someone, we know we have an ethical, moral, and legal duty to care for them as well.
And a child is particularly vulnerable. I assume, Mr. Hastings, you agree with that as well, that any death in federal custody of a child is tragic and on the brink of a crisis.
It is tragic, and yes.
And the idea of those line officers, I call, and I have been and seen the efforts that they've made during some very difficult times, buying diapers, getting formula. I think that should be put on the record. But I think the key point, and I appreciate some of the many great steps that Congresswoman Underwood has made. We traveled together to the border and several times thereafter. But my question would be, is it time now, have we, as you present reports pursuant to the legislation passed, to stand up a very effective parallel medical system based on the present policies of this administration, meaning that asylum is being denied. They're not being able to access asylum in the way that it should. There are migrant camps just on the border in Mexico where disease is rampant or to be rampant, and so that means that when they come over, they may be sick. Do we have an effective medical system that is parallel to your law enforcement system that can do additional things besides, the records that are being done and some of the other aspects of reporting? An effective, almost semi-quasi health center for these individuals that are coming in.
You want me to start? Go ahead. Yeah. Ma'am, I think we have to be very cautious that we confabulate a healthcare facility with a law enforcement facility. We firmly believe in DHS, and it's my personal belief as a physician that healthcare is best provided in a healthcare setting. And so what we ought to continue to do is to facilitate the movement of people through our system to the best place to care for them. For children, that's at HHS. For single adults, that's in ICE custody. But we have to continue to harden the system for the times that we face unprecedented demand for care, and I believe that's exactly what we're doing right now.
Dr. Hastings, Madam Chair, can I just have a quick follow-up? Dr. Hastings, Mr. Hastings, your point on this parallel health system.
No, I would agree completely. We want, the Border Patrol and CBP wants to see UACs, vulnerable populations, out of our custody as quickly as possible. That's what we want to see, to the proper places where they can receive the needed care.
So let me ask this quick question, because it might have been misinterpreted that I wanted a hospital established, and that's not the case. First of all, the children were not out of your custody as soon as possible, and we have some challenges now with a system that I helped set up, which is the HHS system, so we'll put that aside. My point is that there be some process that is more substantial than the law enforcement that can do immediate care besides putting someone in a police car and trying to rush them to the next or the nearest hospital. The question is, do we have an effective emergency response on site that can deal with some of these crises, such as one of the young men, 16-year-old, was found non-responsive, and there was not much to deal with his non-responsiveness. So quickly to Mr. Hastings and Dr. Eastman.
To answer your question, we're certainly going in the right direction. As I alluded to earlier, we went from 3 sectors covered by medical personnel, contract medical support personnel, to now 9. They're in our busiest locations where we need them. We're constantly monitoring to make sure we have them where we need them, and we'll continue to do so. On top of that, we've got 1,500 EMTs that can provide support and do provide support, and I believe that we're taking all the right steps that we need to.
Dr. Eastman?
Likewise, ma'am, our strategy is to provide the right care to the right person at the right time, and I believe we're taking the right steps currently to do that. We reserve, certainly, and I reserve the right to reassess this system continuously as conditions change. But it's our belief at DHS, and it's my belief personally that we are moving in the right direction.
I look forward to that report coming in so I can understand how the system is working.
Yes, ma'am.
I thank the chair for her indulgence, and I yield back.
Thank you. The chair now recognizes the gentlelady from Texas, Ms. Garcia.
Thank you, Madam Chair, and thank you for your vote on waiving me in to sit on this committee. And thank you to the witnesses. I've been following this issue for a great number of years, beginning with the first influx when I was the chair of the Senate Hispanic Caucus in Texas, and have visited probably about 10 facilities, either under the jurisdiction of CPB or ORR. And I've seen the differences in a lot of the medical protocols, a lot of the medical care that's provided in all those different facilities. I must say that I've never found them to be adequate. I've never certainly found them to be a clinic or a hospital. And to just borrow the words of my colleague to the right, Congressman Lee, no one's asking for a hospital. And Dr. Eastman, I know you've made reference to, you can't put a clinic in every single, I think you use the word substation or police department, a facility. I don't think we're asking for that either. But I think what we do want is what many of us have been talking about, is the right protocols, the right screening to make sure we get on it as quickly as possible. I was completely stunned at the lack of any kind of screening that was done in the New Mexico facility. I know my colleague Torres Small talked about the one in her district. That's the one I visited when Jacqueline died. I mean, they literally took a microwave off a table to let her lay there because there was nowhere else to put her. And this was while they were waiting till they could get the transportation and the bus to go on to the facility where perhaps she could get more treatment. And then, of course, she ended up going to the hospital. Are you telling me that under today's protocols, that has now changed? I know you said you visited Luxburg also.
Congressman, I'm telling you that we do the absolute best we can under the circumstances we're provided. And in my opening statement, I told this committee in America that when we were faced with unprecedented demand for care from a large group.
But sir, the question is, has that changed in that facility now? They won't have to remove the microwave to just put her on that table.
Ma'am, the system
they
that's
will have a screening method so that they can detect it sooner to get her on some bus or somewhere to send her on.
If I could take that one. So a lot of our areas have changed. The soft-sided facilities that we put in place in many of those areas, including El Paso. El Paso has a soft side, soon to have a modular facility as well. That will give some increased capability and some increased space that we need, but still many of our stations in many of our different locations, they haven't changed. They were built for a completely different demographic. They have not changed. We've added as much as we can in those locations in the way of food, healthcare products, those types of things. But I mean, they were not built to house for long periods of time at all.
Well, I appreciate your answering, but I still would like Dr. Eastman to...
Yes, ma'am, just to be clear, the system that's in place today, by virtue of the growth and the hard work of a lot of people across the government and CBP, bears little resemblance to what it looked like at Christmas time 2018.
Right, but asking specifically about some of these remote stations, because many people are using that since a lot of the port of entries that they were used to using, they're frankly aren't even allowed to get even close enough to make entry.
So I'll give you the tangible
other
example.
Remote areas. So the question is, has that one now been improved? If someone presented themselves with high fever, chills, the typical flu symptoms.
So I'll give you two tangible examples.
Would that person be put on the same microwave table?
I'll give two tangible answers to answer your question. First of all, the expansion of contracted healthcare allows the Border Patrol to use their 1,500 EMTs in the role they were designed, which was not to be screening personnel inside facilities, but to be outside in the field caring for our personnel and anyone else they encountered. The second thing
that's a no.
Ma'am, the second thing is that there is now contracted support in multiple locations along the border, and we'll take for the record to get you back the exact details of where that contracted support exists today.
So along the entire border of Texas now, there is some screening protocols to ensure that this would never happen again.
Yes, ma'am. We have the tiered approach that I described earlier in this hearing. is in place all along the southwest border.
All right. What about the medical assessment or screening that are there any in place for the folks that are coming through in the migration protection protocols through the Remain in Mexico program? Are they screened at all? Because I'm hearing that there's a lot of people on the other side of the border that have been turned away under this new program that are very, very sick.
Yeah, the care that occurs south of the United States southern border is outside my scope, and I'm not sure what's being done on the Mexican side of the border.
But ma'am, I would add, they will go through medical clearance prior to us putting them into MPP and returning them. So they will go through this same process prior to being returned under MPP. And additionally, there's a map up there that kind of outlines where we are today as far as those 40 different locations that we have contract medical service. I realize we're looking at a bunch of dots on a map, but the fact is over 300 individuals on duty at any given time providing that additional medical support to our agents in the field. That map, we can't see the
So you're
prior
telling me
map.
that although they're being turned away to go back to Mexico, that you do screen them?
The approach, can I just take that one, sir?
Go ahead.
Yeah, the approach to the medical, to the health interview and medical assessment applies to everyone that's in our custody with the parameters we described earlier.
Well, these folks are not in custody, sir. You're turning them away.
Ma'am, if they're in our custody, they get the care the assessments and the care that was described. As I said, it's outside my scope to know what happens to them south of the border.
Madam Chair, obviously, apparently the witness is not understanding the question. I'm talking about the folks that are being turned away under the Remain in Mexico program.
You're going to have an opportunity to ask that again.
Thank you.
Mr. Ranking Member, do you have any additional questions?
Yes, Madam Chair. Madam Chair, before I ask my second round of questions, I ask unanimous consent to submit to the Homeland Security Advisory Council final report by the CBP Families and Children Care Panel, which was established in November of 2019. I ask unanimous consent to submit it for the record.
So received.
Mr. Hastings, would you like to clarify the medical screening that all human beings that cross the border and come in our custody, regardless of what program they're then subject to? Would you clarify for my colleague, Ms. Garcia, and for the rest of the committee?
Thank you for the opportunity, sir. So that is correct. Ma'am, anyone that comes into our facility, regardless of what program or initiative that they're going into, will go through all of that medical assessment, medical screening, and interview.
So are you clarifying that minors, including children, but all individuals that are returned to Mexico under the program prior to being returned receive medical screening?
Prior to return, we still have to process them. So during processing,
What if they're sick?
we go through that.
Let
Then
me
we'll take
let me
them
extend my colleague's
take them to the
line of
appropriate
questioning
medical
here. What
care.
if they're sick?
Then they'll go to the hospital or the appropriate medical care.
They won't, if the screening determines that they're sick, to the extent that they need professional medical attention, we're getting them that medical attention before we send them back to Mexico?
Yes, as evident by the 26,000 we took to the
And
hospital.
that's a policy across the border or only at one location?
That's across the border, sir.
Thank you, sir, for clarifying that. Dr. Eastman, in your testimony, you mentioned the close working relationship between CBP and the Office of DHS Chief Medical Officer. Can you go into a little more detail, sir, about the specialized nature of your team's assistance to Customs and Border Patrol? And also, based upon your observations, how committed has CBP leadership been to expeditiously address in-custody medical capabilities?
Sir, with regards to your first question, and thank you, the relationship literally is hand in hand. Our office and the Border Patrol and CBP communicate constantly. In fact, the CBP Senior Medical Advisor is an employee from our office that's embedded into CBP to help facilitate these issues. The relationship is hand in hand, and we communicate literally at multiple levels, probably it's safe to say daily. With regards to your second question, my direction has been clear, and our direction has been clear from every leader in the department, whether that's at DHS or CBP, The direction I was given, and
What
we...
about the direction that you've received from upchain,
Yeah,
all the way
direct-
to the top?
Yes, sir. The direction I've received has been clear and has been unanimous.
You feel that
Do the right thing.
that the executive branch and our president is committed by their leadership to expeditiously address in-custody medical capabilities?
Sir, I have not spoken to him directly, but my directions come from the secretaries and the commissioners of CBP that I've worked with, and it's been clear, loud, and unanimous. Do the right thing, break down barriers, and take good care of the people in our custody.
And that message has been pushed throughout the chain of command?
Yes, sir, it's been unanimous and loud and clear from everyone I've worked with.
Thank you for your clarification, Madam Chair. Thank you for the second round of questioning, and I yield.
Thank you, Mr. Ranking Member. I now recognize the gentlewoman from Illinois, Ms. Underwood.
Thank you, Madam Chair. I have a couple follow-up questions based on what we've heard today and what was submitted in the written testimony. In Mr. Hastings' written testimony on page 6, I'm just going to read a couple statements. It says, the Enhanced Medical Directive ensures that CBP will sustain enhanced medical support capabilities with an emphasis on children less than 18 years old. These include a health interview upon arrival at a CBP facility. Mr. Hastings, can you further delineate whether those CBP facilities include all Border Patrol stations?
It does include all Border Patrol stations. Yes, ma'am.
Okay, and so then just to circle back on what was just recently discussed by Ms. Garcia and Mr. Higgins, then if it includes the Border Patrol stations for individuals that are brought into apprehension with the idea that they will be put into this migrant, the MPP policy, then you consider that under U.S. custody, correct? Because they are
That's
being
correct.
designated. Okay, so then
Again,
those
we would-
individuals all get a health interview.
That's correct.
Okay, and if those individuals are seen as having some kind of medical flag, to use a casual term, then they will get a medical assessment.
That's correct. Yes, ma'am.
And Dr. Eastman, can you confirm that that is happening in all facilities?
Absolutely, ma'am. And in the locations where we don't have contracted medical support yet,
Correct.
that's continuing to develop, we utilize local resources to get that assessment. So if the interview occurs and if folks need health care and we don't have it there, they'll get it in the local system.
Okay, so just to reiterate, the individuals that are coming to the United States that under current policy, under DHS, you all want to send them back to remain in Mexico or go through the MPP, and they present with a health care issue, you're saying that they are getting both an interview and a screening, and if at that local facility they don't have the medical staff on site to do the screening, you all are sending them externally to get that medical assessment completed.
If they have a medical need, we will certainly utilize the local healthcare system. Yes, ma'am.
Okay. So my follow-up question then is on page 4 of Mr. Hastings' testimony. He says that currently each day there are approximately 300 contracted medical professionals engaged at more than 40 facilities along the southwest border, providing 24/7 on-site medical support, and that support is now available at all 9 southwest border U.S. BP sectors, so U.S. Border Patrol sectors, and all 4 southwest border OFO field offices. So based on that, would you then consider there to be 100% coverage?
No, ma'am, I would not. So as I mentioned earlier, we believe we have about 10 more locations that we need to cover that we're working rapidly to get coverage now. But how we determined where this went was where the highest flow of vulnerable population was, where we had the least medical support in our nearest areas, and the highest flow rate that we were seeing. We have about 10 more locations that we're looking to expand to now still.
And do you have the current funding to support that expansion?
We do have the current funding to support that, yes, ma'am.
Okay, so then the numbers that are submitted in your testimony are current as of what date, right? So these individuals and locations were staffed as of what date?
Into December 2019.
Okay, thank you, Madam Chair, I yield back.
Thank you. Where are the 10 additional locations?
I'd have to look at the chart, ma'am. I can get back to you. I don't have the chart in front of me.
Okay, thank you. I now recognize the gentlewoman from Texas, Ms. Garcia.
Thank you, Madam Chair. Just a quick follow-up. Mr. Hastings, what is the average stay these days for a child in custody?
So that varies, ma'am, from day to day, hour to hour, but on average, the average time in our custody right now is approximately 39 hours the last time I looked.
39 hours.
The last time I looked, yes, ma'am.
Well,
Kids are leaving our custody quickly since HHS is funded.
Okay, do you remember what month that was? I mean, that is obviously not the numbers I'm seeing, so.
It's been a while since I've looked at the tick time. It's one of the time in custody time. That's one of the many variables that we look at. But the point being is,
That's shy of 2 days.
Pardon me?
That's shy of 2 days.
We are doing very well at individuals getting.
Well, let me ask you this. I don't know the age of your grandchildren, but would you be comfortable with having your grandchild in custody in one of your own facilities for 39 hours?
I don't want any child in my facilities for that long, ma'am.
But would you be comfortable?
I'm sorry, in the crisis, for right now, for 39 hours, I trust that our employees are taking good care of the detainees that they're charged with oversight.
So you would be comfortable if your grandchild was there?
I think we're doing very well providing proper services for all those in our custody right now. During the crisis, no, I wouldn't. I don't want them I wouldn't want my granddaughter in custody anywhere, but I think we're doing the best we can with everything we have out there on the border right now, with all the improvements that we have made, and how quickly we're getting these unaccompanied alien children out of our custody.
Right. What about you, Dr. Eastman? I know you mentioned, I don't know if you have children or grandchildren or little nieces and nephews like I do, but would you feel comfortable with a member of your family being in custody?
With no offense to Chief Hastings, ma'am, I'm a little young for grandchildren, but I will tell you that
I never make assumptions. I've learned in this business.
I understand, ma'am. I want to be clear with Chief Hastings that it would be my preference that we don't ever hold children in our custody.
Well, that certainly is my preference, and the child has not committed any crimes, as my colleague from Texas said, Mr. Green.
Well, let me be clear from my perspective as a physician that we provide our care irrespective of circumstances. It does not matter to us what they have or have not done. Our care is provided to every human being in our custody the same, no matter what the circumstances are.
Right.
To answer your question, ma'am, I would be very comfortable with my children receiving care in this system if it were necessary, and I know that we're going to continue to do everything we can to improve it every day.
Right. Let me follow up on my colleague, Mr. Correa's questions. Like him, I also serve on the subcommittee of Judiciary Committee on Immigration. He was asking about volunteer doctors. I know that I'm from Houston. We have a large medical center, which means we have a lot of doctors around. Many of them do a lot of good volunteer work in a number of areas, and many of them do missions abroad. They have mentioned to me that, they've tried to help and tried to volunteer, tried to even bring, especially the flu vaccine, to some facilities. I mean, what is the real beef if they're Texas facilities or Texas doctors and they're willing to help? Why wouldn't we allow them to help?
So just to be clear, ma'am, I'm a Texas doctor as well.
I know that. I saw your resume.
But the provision of volunteer medical support presents challenges not just to the Department of Homeland Security, but to medical organizations in this country, in every state. And so while we sometimes have difficulty with the licensure and administrative requirements, we certainly, and we have done this, we've tried to vector volunteers who want to provide that help to some of the other locations that aren't as fortunate to have medical support like we are, like the NGO shelters along the southwest border. So when we've had Texas volunteers, we've tried to vector them into the Texas NGOs that need help. And oftentimes, while that's not my role as the DHS Senior Medical Officer, we've been thrust into that because in many ways, we're the intermediary between those medical volunteers. For example, you're from Houston. I talk to Dr. Maddox almost daily, and we talk routinely about things like this. We talk to, and one of the things I think that's really important is that during the course of this crisis, we have worked with state and local health departments and doctors all across the southwest border, and it's been a hand-to-hand, direct, face-to-face meetings and working together to solve problems as they arise. We have tried to be the best partner possible to the state and local health departments along the southwest border, and I think Some of you saw evidence of that when you came and visited the border and saw some of those interactions. We'll continue to do that. You've got my word. We're going to continue to try to be the best partners possible.
What impediments or challenges are there, and would it be anything that we can do in terms of legislation to be able to provide, better access to volunteer doctors?
Yeah, my suggestion, ma'am, is that we take this offline and we work together, because the provision of volunteer services in disasters in this, volunteer medical services in disasters in this country is something that we're interested in. It's a tiny bit outside the scope of this hearing, but I would love to work together with you to try to help solve this problem on an
Well,
actual
I think it's
basis.
in the scope not only for this hearing that's focused on CPB, but also we have the same challenge in even volunteers who want to help children that are in our facilities. Even something as simple as taking them to the movies. I mean, some of these facilities won't even allow people to come visit the children in any way to try to assist in terms of particularly their mental health well-being. So sure, we'll take it offline, and Dr. Maddox is a good friend, so we'll make it a three-way call.
He would love that, ma'am.
Thank you. Thank you.
Thank
Yield
you.
back.
Let me just say that I think I can speak for my good friend, Mr. Higgins, the ranking member, but I want to thank Mr. Hastings and Dr. Eastman for coming today. There are people in positions above you who don't show up, who don't answer the call, which is their duty. And so the fact that you two showed up and took some difficult questions, I'm grateful. I'm very grateful, because you could have done what they did. We are well within our constitutional obligation of having a role in oversight. I want to thank the ranking member on this subcommittee, because we have been trying to address this issue. Before anyone is a Republican, a Democrat, black, white, male, woman, we are all human beings and we're all Americans. And I know that, I think I can speak for everyone in this room and certainly on this committee, that even one death in custody is a tragedy. And Dr. Eastman, I remember meeting you before you even got the position, because it was one of the issues we've tried to address is how quickly we can bring qualified people like you in to help solve this problem. And I want to thank you. I know that you've had contact with my colleague, Ms. Underwood, who has a medical background, and it's relationships like this that are going to help us all address these tragedies and ensure that they don't happen again. These are children who are being brought here for a better life, which is all any of us want for our children.
Thank you.
I thank the witnesses for their valuable testimony and the members for their questions. The members of the subcommittee may have additional questions for the witnesses, and we ask that you, some of which we spoke about during the questioning, and we ask that you respond as expeditiously as possible in writing to those questions. Without objection, the subcommittee record shall be kept open for 10 days. Hearing no further business, the subcommittee stands adjourned.